special interest in fetal medicine. I'm also an ultrasound clinical application specialist for Mindray in the North Africa office. Today I'll be speaking about the intelligent pelvic floor solutions in ultrasound that Mindray offers. First of all, let's start about a little clinical background. I know this is very, very basic information. This session has a lot of more in-depth. First of all, we know how pelvic floor dysfunction affects almost 1 in 3 women in the world. The most common manifestation or symptoms that females would suffer from, especially is stress urinary incontinence and pelvic organ prolapse. These are the common causes. Of course, it happens with age, repeated pregnancy, repeated childbirth, gynecological surgeries, obesity, and physical activity. The diagnosis has been usually with X-ray fluoroscopy. It has the advantage of better contrast and using the contrast agents. But the disadvantages happen with the reaction to the contrast agent and radiation exposure. Of course, MRI is the golden standard and has been, and it's still the standard technique for assessment of the pelvic floor dysfunction, but it has some, we'll not say disadvantages, but some limitation, like the dynamic methods, like the difficography is not very widespread. The cost, the time of the examination, the artifacts produced by the slings, but of course it gives out the best contrast and supplies good images, especially the axial plane. The ultrasound provides the other. Ultrasound provides the benefits of or avoids the disadvantages of the other modalities, like no radiation, not invasive, very easy, very limited cost. Patients accept it more. It has the virtue of the 3D and 4D reconstruction that can be equivalent to MRI axial planes, and we can get volume acquisition and then do post-processing to it and change the angles. There's no anaphylactic reaction by the contrast agents like in the fluoroscopy. Indication of pelvic floor dysfunction, these are the list of the symptoms that patients might have, and we use the pelvic floor ultrasound for diagnosis or for evaluation, post-operative evaluation of stress urinary incontinence and pelvic organ prolapse, and to follow up the rehabilitation treatment for the pelvic floor. The list of probes we have, these probes are for the transperineal approach. It's not the endoanal approach like the machine that they have in the pelvic floor unit. These are transperineal, the convex that have convex 4D and 3D and 4D and convex 2D. Also the transvaginal that has 3D volume, or the biplane endoanal probe. This is the approach. If you are using the transvaginal or the endocavitary probe, it has to be outside. It shouldn't be introduced beyond the symphysis pubis to be able to get the reference line we are seeing here. These are the images that we can get during breast or Valsalva. We can see here how the cystocele is passing the reference line set by here. We need to get the bladder neck to symphysis pubis distance. The other approach is by using the transperineal, using the convex probe. This is the images that you usually see. And the measurements for pelvic floor ultrasound are usually very complicated and hard to need a certain level of practice and certain level of experience to get the bladder neck symphysis pubis distances and the angles. But these are the measurements that needed to be done to get the diagnosis. The reference ranges for the retrovesical angle and the urethral rotation, urethral tilt angle. These are the reference ranges. And we need the 3D volume acquisition of the pelvic floor to assess the integrity of the levator hiatus muscle and the area. We usually also need to get the dimensions of the area of the levator hiatus. These are almost the cut-off numbers. They change with areas, like for example in the Mediterranean, African regions, it's 25. For Asian regions, it's 20 centimeter. And the risk of pelvic organ prolapse is increasing if this hiatal area increased more than 25, and if the lateral urethral gap is more than 25 millimeters. The challenges of the pelvic ultrasound examination is usually the many measurements that you need to take, which can be very time consuming and needs some certain level of experience. It's also difficult to confirm the reference line to make the results accurate and reproducible. And on the 3D level, we need to have repeatability, and reproducibility is not good because you'd have to trace all around the levator hiatal area. What Mindray offers, first of all, in the 2D translabial or transperineal approach, you can just get to assess the reference line. In this case, the reference line is at the axis of the symphysis pubis, and then you would just set some points to the important areas. Like here is the first one at the symphysis pubis, and then you do it at rest, and then you repeat it again at Valsalva. Here, symphysis pubis, the reference line, the bladder, the bladder neck, the external area, the external proximal part of the urethra, the posterior wall of the urinary bladder to get the retrovesical angle, and then V stands for the most proximal part of the posterior wall of the urethra, and then the machine will do all the calculation, the rest of the calculation on its own. Here, what stands for, and the intelligent measurements in this one, that the machine would auto-recognize the scenarios that we are working on, that is pelvic floor, and that will produce the values in sequential manner. In 3D and 4D, and doing 3D and 4D smart pelvis, we have the technology that's smart scene technology. It auto-recognizes the pelvic floor scenario, and then it will adjust the region of interest site and position to the optimum area. It will auto-acquire the volume acquisition, auto-rotate and optimize for best visualization, and then auto-complete the area measurements. Here we can see all the measurements, and I get the three needed planes for the minimal hiatal images, and then we can do more processing of this image. We can get the anteroposterior hiatal diameter, the lateral hiatal diameter, the levator hiatal area. All of these measurements are done automatically. The intelligent smart tool for the smart pelvic, the benefits of it, it's the speed and simplicity. It's very standard. It's used the standard. These are comparison between the time taking for assessment of the anterior compartment or the levator hiatal area, the difference in time and keystrokes, and the reproducibility of the results. And it used the standard mainstream standard systems for the reference line. For example, the horizontal reference line, this is used by Professor Hans-Peter Dietz by using the trans-abdominal volume probe, and these two reference systems are using the transvaginal volume probe. Now, these are the probes that we usually use, and the differences in the frequency and the angle. However, the transvaginal probe produced better resolution, better frequency, and wider field of view, and wider sweep angle, but it's very hard to control more than the convex probe. The machine also has a comprehensive pelvic floor ultrasound package that it had the dedicated pelvic floor exam preset. It has the dedicated measurements package and calipered for especially for the pelvic floor. It has dedicated annotation and body marks packages. And these are other applications for post-processing of the 3D and 4D volume. You can get to use to produce these multi-planar images at the pelvic elevator hiatal area or at the anal canal and anal sphincter, and get to watch it in like CT or MRI multi-planar images. Also, you can use the curved MPR, where you can draw a line that passes through the symphysis pubis and it passes through the elevator hiatal up to the anorectal angle to get a better assessment of the elevator hiatus area. And finally, this is one case where for assessment of the stress urinary incontinence. This is during rest, and then we repeat the same procedure again during Valsalva maneuvers. That's supposed to be around to teach the patient how to push for around 6 seconds until we get to the maximum Valsalva. Now, here, we do the measurements again. This is the reference line. That's the horizontal line from the lower margin of the symphysis pubis. And then all the measurements are sequentially taking, and then it will calculate the bladder neck descent that was about 3 centimeters in this. The neck descent was about 3 centimeters in this case. Thank you. Any question?
Thank you, Dr. Raghda, for your presentation. Okay.